Hello, everyone, and welcome to the Cancer Support Community's educational webinar. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm honored to welcome you to this week's webinar titled Breast Cancer Update, a presentation on the latest in prevention, diagnosis, and treatment of breast cancer in 2023. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. And our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not be able to get to all of your questions today, but we'll get to as many as possible. Dr. Parvin Peddi is the Director of Breast Medical Oncology at the Margie Petersen Breast Center at St. John's. She completed her medical training at Duke University and internal medicine residency at Washington University. She finished her hematology oncology fellowship at UCLA and saw patients and conducted research at the Revlon Breast Center, teaching medical students, residents, and fellows before moving to St. John's in 2021. It gives me great pleasure to welcome today's speaker, Dr. Parvin Peddi. Thank you, Dr. Peddi.
Thank you. Thank you very much, Kathy. Thank you very much for having me. It's always a pleasure to give talks to Cancer Support Community, and you guys are a really great resource for all our patients. So thank you for all that you do. And very nice to see so many familiar names in the participants. And I will, have a talk on breast cancer. It's hard to squeeze everything about breast cancer into one presentation. So it will be a bird's eye view of all the different aspects from diagnosis to treatment, but I really want to leave plenty of time for question and answers so that we can get more into details in portions that are of interest to you. So let me go ahead and share my screen. All right. So I will start with diagnosis. So when a patient comes in for their screening mammogram, or they have a palpable nodule and they undergo a mammogram, when a mammogram is able to see a mass, this is what it looks like. So you can see this density that is white that is on the mammogram, and then, or typically, if at the same time even, If it was a palpable, the patient also has an ultrasound, and this is what the ultrasound would look like. That you can see the mass. Sometimes you can see, if it's cystic, some fluid things in there, but if it's like a tumor per se, then there wouldn't be any fluid in there. And then the radiologist would be saying, this is suspicious, this is not nice and round like a cyst, doesn't have fluid, and it needs to have a biopsy. And sometimes also we do MRIs for patients at the time of diagnosis. And that depends on a few things. Main thing is if the breasts are dense and the patient is young, because the younger one is, the denser the breast and the harder to see on mammogram, the mass and the extent of it. And if there's a lobular cancer, a lot of times we do MRI because lobular cancer is very infiltrative and it can be hard to see as one single mass. And therefore, mammogram ultrasound can underestimate the extent of a lobular cancer. So can MRI, but MRI is more accurate on average for these patients. And then just for surgical planning, just to make sure we're not missing anything anywhere else before the patient has their surgery. And this is what an MRI would look like. So basically, it's, this particular person is a mass is much bigger and is on this side, as you can see. And the rest are just the normal blood vessels. And MRI automatically images both breasts, so everything can be seen. And then when people are diagnosed, who gets genetic screening? That's a big question that I get asked a lot. Did I get this because of a gene? Or why did I get this? Because nobody in my family has breast cancer. So it's important to know that only 5 to 10% of breast cancers are hereditary. The rest are not, and has nothing to do with one's family history. The most common genes are, BRCA1, BRCA2, and PALB2, and there's another one called CHEK2. But there are a number of genes, and right now, this day and age, when we do genetic testing, it's very comprehensive. It's 20 plus genes that are tested to see if any of them could have anything to do with the person's breast cancer. And on average, people that we do genetic testing for, people who are younger, people who have family history, male breast cancers for sure, people of Ashkenazi Jewish descent, and everyone who has metastatic breast cancer also gets genetic tested, not because it's more common to find a gene if you have metastatic cancer, but because there is a specific drug approved for those patients only if they have the BRCA gene mutation, because it would change their management. That's why all of them, despite the fact that most of them won't have genetic mutation, will get genetic testing. So, okay, somebody has been diagnosed with breast cancer, one way or the other. The next question is, what is the stage? So stage refers to where the cancer is, right? So how big is it in the breast? Is it a lymph node or not? Is it outside of the breast/lymph node area? So stages 1 to 3 are confined to the breast and or axilla. And the higher the stage, the larger it is, or is in more lymph nodes. And then once it's gone or can be detected in any other organ outside of the breast and the lymph nodes, is by definition stage 4. And stage 4 can be just in one organ system, like in bone, which is a very common place, or it could be in multiple. Regardless, is in one category as a stage 4 breast cancer. So aside from that, the stage, it's the type of breast cancer is important for patients to know. And the two ways of saying what the type of the breast cancer is. One is it lobular versus ductal? And I kind of touched base on this already in terms of needing MRI for lobular cancers. So those are the two main tissues that are in the breast. So breast cancer can start in the ducts that carry the milk towards the nipple, or it can start in the lobules that actually make the milk. Majority breast cancers actually start in the ducts. That's 90% of breast cancers, and about 10% are lobular. Lobular ones are not any worse. It's just that A lot of times they're higher stage by the time we find them, because they're harder to find to see on mammogram. But stage by stage, if you have a stage 1 ductal versus stage 1 lobular, there's no difference in terms of how well the patients do, and the treatment is the same. It's more important, once someone knows they have breast cancer, whether the cancer relies on estrogen, progesterone, or HER2 for its growth. So estrogen and progesterone are, the usual hormones that normal breast tissue relies on for growing. And a lot of breast cancers use the same thing for their growth. So the breast cancers that like estrogen are the most like a normal cell and usually the least aggressive types of breast cancer. And then this third thing, HER2, is a specific protein that you can see is a little schematic here. Like any normal breast tissue has HER2 on the surface of it, which is a protein. But when we say HER2 positive cells, they have millions and millions of this on their cell surface. And what this protein does is that it basically activates the cancer cells in a much more stronger way when it's activated from factors from the outside, and leads to a more aggressive breast cancer. More in terms of its growth, in terms of its metastatic potential, and represents about 20% of breast cancers. And prognosis for this type of breast cancer used to be much worse compared to other types of breast cancer. But since the last 40 years or so, we've come up with a lot of targeted agents against this protein. And now actually, if you treat patients correctly, they do better than other types of breast cancer, but the treatment does require chemotherapy even when it's early stage. So the goals of therapy, if it's stage 1 to 3, the goal is cure. The goal is to get rid of it with surgery, chemotherapy if needed, anti-hormonal therapy if needed, and radiation if needed, depending on the stage and the type. If it's metastatic, unfortunately at least now, and with our science at the moment, we can't cure patients with metastatic cancer, but we can induce remission in the cancer most of the time, and prolong life and improve symptoms, and then hope for better and better things to come along as you're undergoing treatment. So therapy, and this could take like weeks for me to go over, depends on the type of breast cancer. So I'll briefly mention each one, the highlights, and like I said, we'll leave plenty of time for question and answers. So 3 categories: hormone receptor positive breast cancer, HER2 positive breast cancer, and triple negative breast cancer. So we'll go one by one. So when a patient is diagnosed with a hormone receptor positive breast cancer that is localized, you want to obviously do surgery. And a lot of times you don't do any treatments before surgery. You just go for upfront surgery unless it's really big and they need treatment beforehand for this cancer, because the surgery just cannot be done. But a lot of times it's upfront surgery. And then after surgery, everyone is recommended to have something that goes throughout their body in case there are cancer cells that are still left behind. And that's, sometimes hard for people to understand. People who, maybe are meeting the medical oncologist for the first time. They say, but the surgeon got it all and the lymph node was negative. Why do I have to still do something? Because even when the lymph node is negative, first of all, the surgeon didn't sample every lymph node there is. They just go with the sentinel lymph node and stop there. And there could be cancer cells in other lymph nodes, or they could have gone through the lymph node and already be beyond it and didn't actually make a home there, or just gone directly to the bloodstream. So the lymph node is a way of, putting people in different baskets of like higher risk versus not. But even when there's no cancer in that 1 or 2 lymph nodes that were sampled, we know there's a risk of the cancer still being out there because it was invasive microscopically. It broke through the duct wall or the lobular wall, and those patients need to have something. Now, what that something is, because it's hormone receptor positive, is going to be some kind of anti-hormonal therapy plus or minus chemotherapy. So in terms of how do we choose whether someone will do chemotherapy in addition to the anti-hormonal therapy, it depends. So for the lymph node negative patients and people who have like 1 to 3 lymph nodes only positive, there is a test called Oncotype DX. And it's a very cool test that is basically a genomic analysis of the cancer. The company that developed this picked 16 genes that we know are important in cancer wanting to get out of the breast and cancer being more becoming metastatic and cancer also responding to chemo. So it takes these 16 genes and figures out the expression level of them and puts in a complicated formula, spits out a number on the other end, and that number then puts people in low risk, intermediate risk, and high risk categories. And people in high risk now would benefit from chemotherapy, and people in the intermediate then it requires a discussion depending on their age and other risk factors, and low risk wouldn't need chemotherapy. So the typical cutoffs are postmenopausal women up to a score of 25 do not benefit from chemotherapy from this test. But premenopausal women, their cutoff is a little bit lower because chemotherapy can actually help suppress the ovaries as well. So it has an additional benefit. And up to 18, we know there's no benefit. Between 18 to 25, there's a discussion to be had with the patient to understand whether they would benefit or not. And whether they get chemo or not, these patients, sometimes we add other drugs to the anti-hormonal therapy. So there's a drug belonging to the class of CDK4/6 inhibitors. So these drugs inhibit the cell cycle, inhibit the cell division, is a form of a pill. And the drug's name is abemaciclib and is approved for this indication for patients who have early-ish breast cancer, but is in the lymph node, so they're a little bit higher risk. So in addition to anti-hormonal therapy, when they get to that portion, they also get on this medication for 2 years. And a lot of other, these patients also get started on Zometa, which is a class of drugs called bisphosphonates that help the bone, help the cancer, help prevent the cancer going to the bone and increase cure rate for these patients. And you do that for about 2 to 3 years as well. So I'm going to move on to HER2-positive breast cancer, but in terms of hormone receptor positive breast cancer patients who have metastatic disease, the treatment is very similar. You also start with anti-hormonal therapy plus a CDK4/6 inhibitor in these patients, and actually not chemotherapy. And for as long as possible, you continue with this anti-hormonal therapy, and only when the cancer becomes resistant to this, then you start chemotherapy for these patients. So for HER2-positive breast cancer, treatment is a little bit different, not just the type of treatment, but also the timing of it. So as I said before, like for the hormone receptor positive patients, I said you go for surgery first. Usually that's the first thing. But for HER2 positive patients, usually, unless the tumor is very, very small, you do chemotherapy first. And that's not because, oh, this is a 2-centimeter cancer. It's not that the surgeon cannot take it out. It's more because you can, first of all, really assess response and also give patients something different after surgery if the treatment was not completely effective, that is specific drugs that are approved for that indication. So the HER2 is over here, and when it binds to Herceptin, which is an antibody against HER2, it blocks it from activating the cells. And this Herceptin is basically a backbone of treatment for these patients. So these patients then before surgery, they get chemotherapy in addition to Herceptin, which is this antibody against HER2. A lot of times also this other drug called pertuzumab or Perjeta, which is another antibody. And you do them all together every few weeks, and then you go for surgery after you do that a few times, and then there's a decision tree at that point, depending on whether they have a complete response, meaning actually no cancer at all found at the time of surgery versus not. Our goals are pretty lofty. We really want no cancer at all left, and if there is some cancer still left, there's a cool drug called Kadcyla that I'm going to show you here, that is approved for those patients. So you do the surgery, and if the cancer is completely gone, you still do Herceptin every 3 weeks for 1 year. If it's not, then this drug called Kadcyla, what it is, or TDM1, another name for it, is that, so this molecule is Herceptin itself, so the antibody. But what they did is they coupled it with chemotherapy drugs. So this little tiny thing is a chemotherapy drug called DM1, and they put several of it on each Herceptin molecule. And so what happens when they give the whole thing IV, it comes into the body, into the bloodstream, and then the Herceptin part, this part, finds the HER2 and binds to it. Then the whole thing, including the chemo that is attached to it, comes inside. Only when it's inside the cell, the thing is broken up and the chemo is released. And the chemo then attacks those cancer cells. So this is the first so-called smart chemotherapy, chemotherapy that doesn't attack everything that moves, but actually attacks only the HER2 positive cells. Was approved for breast cancer, and it was approved in 2019 for after surgery. So after you've done the traditional chemo and it didn't completely work, you can do this to try to finish the job, and it actually cut the risk of recurrence by half when it was using this indication. But you see, if you go for surgery at the beginning and you give the same chemo to these patients, you don't know who would have also benefited from this. So they lose an opportunity, those patients, for a more complete treatment. We actually have now a second smart drug in breast cancer. It's called Enhertu, and this drug, same mechanism, it's just a different chemo drug that is attached to Herceptin, that seems to be even better than Kadcyla, is right now approved in a metastatic setting for HER2 positive patients, as well as HER2 low patients. So HER2 patients who don't have millions of HER2, but have some HER2, and they have metastatic cancer. This drug is good enough that still finds that little HER2, and the chemo goes inside. So the ongoing clinical question right now is, can this beat Kadcyla for the early stage? We don't know that yet. So we're not using this drug yet for patients who are getting treatment and surgery, but there's an ongoing trial comparing it to Kadcyla to see if it's even better, which I assume it will be. It's just a question of whether the side effects are going to be worth it or not, because it's a little bit more toxic in terms of tolerance compared to Kadcyla. So that's the whirlwind of HER2 positive. Now a little bit about triple negative breast cancer, and I'm going to actually finish up soon and open it to question and answer. So triple negative breast cancer is when you don't have, the cancer doesn't have estrogen, responsiveness, doesn't have progesterone responsiveness, doesn't have HER2, and it's a big basket of cancers that you can't basically categorize any other way. And it's not that they're all the same. They probably are different baskets of cancer types in there. We just haven't learned yet how to divide them and find targeted agents for each one of them. So right now they're treated as one, and basically blindly for the most part, as all of them kind of the same for the most part. So the traditional treatment is chemo. But because you don't know which cancer is what, and which triple negative responds to anything you give it, and which triple negative really needs a lot of different chemos, it's critical that these patients, when they present, in the early stage, like the HER2 people, positive patients, get chemo before surgery. Because when you give chemo before surgery, you can follow this, see how people are doing. If your chemo is not enough, the cancer is not shrinking, do something different, do something extra. And if you're making progress, don't add every chemo under the sun and try to limit toxicity. But if you go with surgery first and you're treating microscopic cancer afterwards, and you have no idea if your chemo is working or not, you can't modulate anymore. You can't escalate or de-escalate at all. So critical that patients with triple negative breast cancer see a medical oncologist and not jump to surgery at the beginning. And then a cool thing that has been now approved for a lot of patients with triple negative breast cancer is immunotherapy. We haven't yet figured it out very well for other types of breast cancer, but for triple negative breast cancer, at least a subset of them, we have figured out how to work this. So what is immunotherapy? Because a lot of patients hear about this, whether they have triple negative or not. And the question is, how does it work? So look at the diagram on the left. So this is a tumor cell, and this is your white blood cell, a type of white blood cell called a T cell. Ordinarily, the tumor cell or any cell that is behaving badly has proteins called antigens on its cell surface that are not normal. They're not supposed to be there. But because this cancer cell is acting wild and expressing all these proteins that shouldn't be expressed, has all these things on the surface that shouldn't be there. And your immune system is usually pretty good at recognizing these things. That's how it fights infections. That's how it destroys abnormal cells. So it has a receptor that would find this antigen. But what the tumor cells, a lot of them have learned to do, they have an extra thing. This thing called PD-L1, programmed death ligand number 1. And that is a different protein that finds its own receptor on the T cell that then signals to the C cell that, no, ignore this. I am actually okay. So this signal completely can trump this one, and the T cell no longer attacks this tumor cell. So this has been known now for a few years. And so what medical oncology has done, tried to develop drugs that either block this or block this, so this interaction cannot happen. So they are anti-PD-L1 drugs, they are anti-PD-1 drugs, and basically that's what they do. They block either the keyhole or they block either the key, so this interaction can't happen. So then the T cell is like, aha, I see you. You're not supposed to be here, and goes to try to destroy them. And a lot of times in combination with chemo. So because chemo makes more of these antigens get expressed on the T cells because it goes under stress and goes into production of these cell proteins that shouldn't be there. So because triple negative breast cancers are more aggressive, they have more of these proteins on their cell surface, these abnormal proteins. So that's probably the reason we have found a way to make it work. So immunotherapy right now is added to chemotherapy for a lot of triple negative patients before surgery. So they do the chemo plus the immunotherapy, then you go for surgery, and then a lot of times the immunotherapy is continued afterwards for about a year or so. And then for patients who have metastatic breast cancers also, but for them, you really need to have the tumors express this PD-L1, because some triple negative cancers don't do that, and they have other ways of going around the immune system that have not yet been enough categorized. So you have to have this expression in order to be able to have the immunotherapy work. So everybody who has metastatic triple negative breast cancer, the pathology department is supposed to test the cancer also for this, so they know if, so they can tell the medical oncologist, can you use immunotherapy or not. So in conclusion, breast cancer can be curable when it's diagnosed early. Treatment obviously involves surgery, but also frequently chemotherapy, hormonal therapy, and radiation therapy. So ask to see a medical oncologist in addition to a surgeon when diagnosed before surgery. And yeah, so breast cancer is a very multidisciplinary modality, and we need all of the doctors to work well together. And yeah, so it's critical that the center that you go to have doctors that talk to each other, or doctors that coordinate care with each other, so that you can get the right sequence, and not just the first doctor that you see does their thing and go ahead, which does happen, believe it or not. So I'm going to open it up with questions, and I'm going to stop sharing. Sorry, I have a cold. So let me see about the question and answer. Somebody asked, is it recorded? Yes, it is, and can be viewed online. So I don't see any questions yet. So I don't know if I'm missing it or not, but please let me know if any questions. And Kathy, if you're on, you're welcome to jump on too.
Yeah, we did receive a few questions at registration. So why don't I get started with those, and then we invite everyone to post any additional questions into that that Q&A feature, but thank you so much for joining us today. Someone was asking in registration, could you clarify what's important as far as having a healthy lifestyle post breast cancer treatment?
Sure. Yeah, the thing that is important for people to recognize is that majority of people didn't get breast cancer because of an unhealthy lifestyle. It's a cancer that very loosely is associated with lifestyle. And on the flip side of it, you don't need to turn your whole lifestyle around when you get breast cancer, if you do. Now, things that we do know have something to do with either survival or ability to tolerate treatment are the following. One is a good healthy weight, especially for patients who have an estrogen positive breast cancer, because a big source of estrogen is fat tissue. So if patients are overweight, they have more estrogen on board. And that is not helpful, obviously, in general, in terms of their health and cardiac health and everything, but also in terms of estrogen production and feeding of this cancer. And probably in the beginning also even increases the risk of breast cancer, but there are plenty of people who are not overweight who get breast cancer as well. So that exercise, aerobic exercise, does improve the immune system. And the better your immune system, the better, hopefully, you'll be able to catch cancer cells that are trying to recur. And third, I would say limiting alcohol consumption. So alcohol also increases estrogen production. So the current recommendation for women is less than 3 drinks a week, because we do know that the more someone drinks, the more estrogen they have on board. Now, other things are less clear. So antioxidants, let's say, whether it's through food or supplements or green tea, probably helpful, but it's hard to know how helpful and how much to do. Soy products are probably okay. There was a while that we told people not to eat soy products, and then we told them just eat soy products because there are conflicting data on this. So I tell people in moderation is fine. Soy products. And caffeine is okay, chocolate is okay, all those things are fine. So I think the main things are exercise, maintain a good weight, and limit alcohol. And if you're on an anti-hormonal therapy medication, make sure you take plenty of vitamin D and calcium so your bones are in good health, because those medications can have a negative impact on the bone. Those are the things I would say.
Great, thank you for that. And I see that we now have several questions in the Q&A, so I'll let you take it from here. And Dee, someone named Dee has their hand raised.
I can see them now. Well, hand raise, I think we were not going to do like you need to put in the chat, right?
So maybe type your question into the Q&A if you can, Dee.
Okay. And I'll just start from the top and go through the questions. Someone said I was not informed about my oncotype result. Does it mean that I wasn't tested for it? Perhaps. So not everyone needs to be tested for oncotype. It doesn't apply in HER2 positive or triple negative breast cancers. It only applies to estrogen positive breast cancer. And it only applies or needs to be done in situations where you are on the fence about chemotherapy. Your oncology is on the fence about chemotherapy, meaning it's not completely clear whether you should or you should not. Because if the pathology is very straightforward that you do not need chemotherapy, let's say it's a super tiny, less than 1 centimeter thing, is low grade, very hormone positive, that cancer is not going to need chemotherapy. So I actually encourage patients not to send oncotype. You may think more information is always good, but it can confuse the picture because any test can sometimes be wrong. And you don't want this one test to trump everything else that says you should not be getting chemotherapy. So I only send it in situations that make sense. And on the flip side, if patient has multiple lymph nodes positive and they're really high risk or the tumor is high grade, if it's pretty clear from everything else that they need chemotherapy, in that scenario, again, I wouldn't send Oncotype because I don't want it to confuse the picture. So because I have seen Oncotype give a wrong answer, and by wrong I mean like you send there's a European version of it by a different company, and you can get different results from Oncotype and that other thing. So one of them has to be wrong. So it's not automatically sent on everyone, and when I don't send it, there's a good reason for it. So if you don't know about the result, it was probably not tested for any number of those reasons. Next patient, person is saying, why is lobular treated luck ductal? Because if is estrogen positive, let's say, it responds to anti-estrogen treatment. If it's HER2 positive, responds to that. So in all the trials that have been done on therapy, when they separated out ductal versus lobular, there was no difference in terms of response, as long as you knew what type it was in terms of what it relies on for growing. So that's the reason, because we know based on studies that it still responds to the same exact things. It's more what it relies on for growth that is more important, rather than whether it was ductal or lobular to begin with. Is Verzenio as an effective treatment for hormone receptor positive breast cancer? Yeah, so Verzenio is the one that I mentioned, is a CDK4/6 inhibitor. The other name for it is abemaciclib. That's the generic name. And but it's the study that was done on this, it restricted the patients that were enrolled to only very high risk patients. So patients who had 4 or more lymph node positive for the most part, or the cancer was really big, like more than 5 centimeters, really high grade. And it showed a benefit in those patients. But most likely the patients who are lower risk than that, their prognosis is so good already that it's going to be hard to tell a difference between, whether Verzenio also improved that or not. And it does come with side effects. It's not the easiest drug in the world to take. It can cause fatigue, diarrhea. And so even patients that want to take it and need to take it, sometimes we have trouble getting them through the 2 years. So depends on the situation, but yes, it can be an effective treatment in combination with anti-hormonal therapy for the treatment of those patients' breast cancer. Next question. So why did my daughter receive surgery before chemoimmunotherapy for HER2 positive breast cancer that went into 2 lymph nodes, age 31? I don't know. First of all, immunotherapy is not really done for HER2 positive breast cancer. So unless they were treated on some kind of study protocol, that wouldn't be standard of care regardless. And why for HER2 positive you would do surgery before, it's either because you didn't really know it was HER2 positive, or it looked really tiny and you thought it's not that much, and then you got a surprise during surgery. Or there was not enough communication between the doctors. I don't know which one, without knowing the specifics, but for most HER2 positive breast cancers, you do want to give chemotherapy combined with anti-HER2 therapy before surgery, especially if you know it's in the lymph node. But maybe for her, they didn't know and they thought it was very small. If it's super small, then you can do surgery first, because if it does turn out to be super small even after surgery, then you can de-escalate what chemo you do. You can do just one chemo drug and Herceptin. So that would be the reason to go for surgery first if you think it's very, very small. Next question. Stage 0 DCIS. So what to do about that? So I didn't really talk about DCIS very much. I didn't want to go over too many things. So what DCIS is so-called stage 0 breast cancer, and it's cancer in the sense that it's cancer cells that look identical to other type, other more advanced breast cancers when you look at them under a microscope. But when you look at them under a microscope, you cannot see any invasion of the duct wall, any invasion that would say that cancer has learned how to get out of the breast. So Therefore, when you treat those patients with surgery plus or minus radiation, and you take that thing out that was so-called precancerous, you're good. You don't need to worry about the rest of the body. And those patients have an excellent unchanged survival from this DCIS, and you don't have to worry about it coming back in the rest of the body at all. Now, some patients still are recommended to, or at least discussed with them, to take an estrogen blocker after this diagnosis. So if the DCIS is estrogen positive, or was, and is now taken out, one could take an estrogen blocker, same as, people who have invasive cancer, for up to 5 years to decrease the odds of this DCIS happening again, or even a new breast cancer on the other side or in that breast. Their survival will be unchanged because their survival is already unchanged, and they're not going to die of breast cancer if they have DCIS. So the only thing this would accomplish, this pill, would be risk reduction in general, and maybe reducing the odds of needing another surgery down the line and dealing with, DCIS or little invasive cancer again. So it's a nuanced discussion when I discuss this with patients, and I take into account how big the DCIS was, how young they are, any other risk factors, how worried am I about this DCIS or new invasive cancer happening in them, and what their feeling is in terms of side effects, because these things can have side effects. So it's a good long discussion, and I completely agree with you about concern about side effects, because if it's not going to make you live longer, it has to be worth it. And some people are much more okay with just another surgery down the line than every day taking a medication that's going to have them side effects if it's a lot. Okay. Can you explain what inflammatory breast cancer is? So inflammatory breast cancer is basically this aggressive type of breast cancer that usually is triple negative, that it's affecting the skin, and it's really like, it's this like generalized thing. It's not this one mass. It's sort of like the whole breast is red, and the skin has this, like, we call it pewtery orange, like it looks like a orange skin peel. Has these like little dots because the whole skin is involved. So those cancers a lot of times are triple negative. So usually we do chemotherapy before surgery also, because again, it's this very generalized, very aggressive process. And usually people need a mastectomy because it's very usually again involved, and the skin is even involved. But once you get it treated, a lot of times they respond really well to chemotherapy. So it doesn't necessarily have to have a bad outcome, but you have to take it seriously and really treat it aggressively. Okay, why would a triple negative breast cancer mother with no genetics have a daughter who also has a HER2 positive breast cancer with no genetics? I don't know. Now, there could be two reasons. One is random luck, right? 1 out of every 8 women gets breast cancer. So it's possible to have a mother and daughter randomly get breast cancer that is not related if, the prevalence is already that high. Or number 2, there is some gene that you both have. We just haven't found that gene yet. So yeah, at this point, the answer could be either one, and it would be impossible to know. If I had a double mastectomy after invasive lobular and stage 3, how will I be screened for future? So yeah, it's a difficult question. So if someone has had mastectomy, there's no more mammogram to be done. And there is very little breast tissue still left there. It's not 0, but less than 5% of what you started out with. So can there be recurrences after mastectomy in the breast? Yes. Is it common? No. And mammogram is going to miss it and is not going to look for it. But so it's not recommended to do MRIs instead. Now, in my practice, I do it for patients who have either BRCA mutation, so I'm really worried about a new breast cancer, or they had many lymph nodes positive, so I'm just worried in general that the cancer is going to come back, but it's not standard of care. So standard of care would be physical exam and, your doctor examining you, the lymph nodes and the breast, the post-mastectomy. and blood work. And truthfully, like, the cancer risk is not just in the breast at that point, it can be anywhere in the body. And we don't scan people up and down all the time because that's a lot of radiation, and it doesn't necessarily change the outcome, because it has to be a certain size before you can detect it on the scan as well. And you would know it a few months later anyways, with symptoms and so forth. So it's blood work and physical exam for the most part, unless you have a BRCA mutation or you already had a recurrence post-mastectomy. In those situations, I would do an MRI, perhaps annually. If you've had triple negative breast cancer, can you get another type of cancer? So if you've, you can. It would likely be a new type, like for whatever reason, like a new cancer, not a progression of that one. If it's more the other way around, like someone has a hormone receptor positive breast cancer, and perhaps over time it can become triple negative because of becoming resistant. But usually it's not that you have triple negative and get a hormone receptor, but anybody can have another cancer, but low likelihood. Any research on curing metastatic breast cancer in the horizon? Well, we are optimistic about immunotherapy. Some of the patients who have a good response to immunotherapy seems to last for years, and is a newer thing that we're doing. So who knows? Maybe some of those patients are getting cured. So only time will tell. And the other thing that is sometimes possible is if a patient comes in, they have metastatic, but is only in one place, let's say, then you could potentially do surgery or radiation in that other place, and maybe they are cured, but it's unclear at this point. So I would say immunotherapy, and then better and better drugs like these CDK4/6 inhibitors that are now on the market that weren't 10 years ago. So we'll see with time if any of these patients who are having really prolonged remissions are actually cured. How is metastatic breast cancer diagnosed? By imaging. So usually either like the lymph nodes were positive, so you're scanning the body just to see how everything is, or labs are abnormal, or the patient has symptoms like in their bone or a cough or a headache or what have you, and then you scan them with a CT scan or a PET scan or MRI, and then if you find something, then usually it requires a biopsy for you to really prove that it is breast cancer, because and to know the type. And that's how it's typically diagnosed. How reliable are tumor markers? So they're not very reliable. These are labs that are done, for sort of surveillance, and some cancers make them, but a lot of cancers don't. And you can also have fluctuations of this. Even normally, like people without any breast cancer can have this. So we don't yet have a really good blood test for breast cancer, but we're making progress right now. The latest is probably this test called circulating tumor DNA test that for patients who've already had breast cancer, to see if they can detect fragments of the DNA of these of the same tumor in the blood, and perhaps we'll make more and more progress and become more and more reliable, but that's a research area at this point. Okay, I saw in the news about some newer mammograms with AI technology and specialized ultrasound. What do you think of that? So yeah, that's an area of that is happening before our eyes. I would say probably more and more integrated as years go on. It's unclear right now how much is really adding in terms of the AI. And definitely you still want the radiologist to look at it. So we'll see. We're not there yet. And then in terms of the ultrasound too, there's this thing called ABUS, which is an automatic breast ultrasound. that can be done in combination with mammogram. And I do recommend some kind of ultrasound for patients who have denser breasts, because we know we miss some things for them. So yeah, so we'll see. Not ready for prime time in terms of the AI yet. I mean, a lot of places are doing it and charging for it, but it's more a curiosity at this point rather than we know it actually changes the outcome. If you already have a good radiologist reading it. After metastases, is lumpectomy or radiation recommended? So if someone has metastatic breast cancer, it's, let's say, in the bone or liver or what have you, at that point, it's out there. So then going for lumpectomy or radiation of the primary thing in the breast is not going to change anything. This thing is circulating in the blood. And we actually have studies comparing patients who have metastatic disease, and half of them got a lumpectomy still, and half didn't. And the people who didn't actually lived longer, because probably when you go through surgery, you have complications with the surgery, you have to interrupt treatment for surgery, and it doesn't actually change the total big picture. So no, unless there is like issues at the site, it's a wound and it's not responding to your treatment, that would be the only reason to do like a palliative surgery. Otherwise, you need something that goes throughout your system. You're not trying to do whack-a-mole and get this or get this, get that. It's out there. So there's no point in putting someone through surgery at that point. Okay. After preventing BRCA2 double mastectomy, do you still need annual MRI, physical exam, and blood work? It's not the general recommendation at this point. Definitely no blood work. I wouldn't do cancer screening in terms of blood work and stuff. I would definitely do the physical exam. Annual MRI, especially if there's an implant there, is going to be not very helpful. But if it's, and they never had cancer to begin with, so it's going to be very low yield. But if there's like they did a flap reconstruction, then you could see behind it. And even though the yield is low, you could still consider it. But I would say for most patients, if they never had a breast cancer and you did the mastectomy before breast cancer, then you're good and you don't need anything other than a physical exam. New types of mammogram screening, we kind of talked about that. Just make sure that you get a 3D mammogram. Most places, major places right now, do it routinely. It was not routine a few years ago, but just make sure that's what you're getting. And if you have denser breasts, make sure that you get something in addition. I would say ultrasound would be a good thing to make sure your breasts are adequately seen. And looks like the last question. What are your thoughts on having complete mastectomy if you have a high probability of cancer? I'm sorry, I don't quite understand what you mean. Like, do you mean you have cancer or you have a high probability of cancer? So if someone has cancer, let's say, and the surgeon can do a lumpectomy and they don't have a genetic mutation, I do not recommend a mastectomy. It's not gonna change your outcome, and it's just gonna be bigger surgery and bigger recovery and all that. If you don't have cancer already, then I would only do a mastectomy if you have one of the major genes, BRCA genes. And then triple negative. So that's the cancer we're talking about that doesn't rely on hormones for growing, and is also not dependent on HER2. But yeah, that's what we mean by triple negative. So basically, it doesn't have a target for its treatment. So okay. Oh, one more question. I think after this we'll probably wrap it up. If you've had a double mastectomy with no reconstruction, mammogram is not possible. Right, if you've gone flat, then there's nothing to do. There's no mammogram, and I wouldn't do ultrasound either. Physical exam should be pretty good. Your doctor examining you, because everything is right there and close to the surface, and they should be able to examine you adequately. So I wouldn't do a screening ultrasound at that point.
Well, thank you, Dr. Peddi. What a meaningful presentation. And thank you to our audience, too, who engaged so wonderfully with us today. We have reached the end of our time together, but I would like to really thank Dr. Peddi for your time today, for your meaningful presentation, and thank all of you who attended. If you would like additional information about the Cancer Support Community Los Angeles, you can visit our website at cancersupportla.org. You can also email us at info@cancersupportla.org. And have a great afternoon. We hope to see you at a future presentation. Thank you, Dr. Peddi.
Thank you all. Thank you all so much for attending. Okay, bye-bye.